All right. Thank you so much for coming to Webinar Wednesday. Carly Andrews, I am the Outreach Coordinator for the North Dakota Brain Injury Network. Thank you for joining us today. We have Jamie with us, and she is a postdoctoral fellow at University of Washington, and she lives in Seattle. And so I will let her do a little more formal introductions. I just wanted to remind you that we do hold these every other Wednesday from 1:30 to 3, so keep continuing to join us. And we will also record this and archive it on our website along with all the other ones. So that is all my housekeeping. So go ahead, Jamie, you can take it away.
Great. Okay. Well, thanks for the intro. I'm glad to be able to pop in remotely and chat with you all today. I am just going to reorient my screen for a second, that I should have done a moment ago. Okay, I'm gonna, as the title implies, I'm gonna talk a little bit about pain management and also just management of other symptoms and experiences following a brain injury. So here's a quick little overview of what I'm hoping to touch on. I'll give a little background on rehab psychology. We'll talk about some of the changes and experiences that we're likely familiar with after experiencing a brain injury. Talk a little bit about self-management, like what that means and why it might be important. And then I'll introduce the study that I was asked to kind of talk about and go into a few different aims and some of the approaches and strategies that we use in that study. So like Carly mentioned, I'm a postdoctoral scholar at University of Washington in the Department of Rehabilitation Medicine. And so my current role is really research focused. And my position's funded by NIDLR, the National Institute on Disability, Independent Living, and Rehabilitation Research. So I'm really kind of in this research realm. And some of my recent experience was a bit more clinical, where I worked kind of in Harborview Medical Center, which is the level 1 trauma hospital here. So all of this is at a risk of over introducing myself, but I think I just wanted to give a little background on University of Washington and their work in the context of traumatic brain injuries and stroke. They're really part of the TBI model system. So they provide multidisciplinary system of rehabilitation care, including emergency, acute, and post-acute services. It's also a comprehensive stroke prevention and treatment center. So they're treating, I think, over 800 patients annually. And in that treatment, it's providing a lot of individualized care plans. I also included I have my PhD in clinical psychology, and I've gone on to receive specialized training in the field of rehabilitation psychology. And I was also able to kind of do some training at a VA hospital in Palo Alto, which where I worked in the polytrauma system. So all of this is to say, a lot of my clinical work has been in kind of the really early stages after brain injury. Sometimes even when I was at the trauma center, it might even be the day of someone experiencing a brain injury or having a stroke. And so all of this to say, I'm not necessarily talking about the acute side today, but really kind of what things might look like over time. And this is kind of where the study comes in. But that's just kind of a little background and context for some of the perspectives and views that I'm kind of chatting about today. So rehabilitation psychology, I wanted to introduce it because I personally feel it's important, but also I didn't even know what it was when I started graduate school. But it's a field of psychology that's really focused on behalf of individuals with disabilities, chronic health conditions, to maximize health, to increase independence, functional abilities, and also participation, and really across the lifespan. And then I included a little link for if you're interested in hearing like learning a bit more. And then we also have like a journal that's dedicated to a lot of these kind of broad topics, and there's a lot of work and research on behalf of individuals with brain injuries. And to that note, I've listed just a couple of the like roles and skills that rehab psychology plays in the context of a brain injury. Psychoeducation, I feel, is maybe one of the most underrated like treatment interventions. I know that even during my time at Harborview at that hospital, a lot of my interventions were very brief encounters where I would provide like simple pieces of education on common symptoms that people experience early on after a brain injury, and if and how those things might change over time, and what things to look out for if things do pop up. Neuropsychological assessments. Some rehab psychologists are trained to kind of conduct these assessments that can provide a pretty comprehensive overview of individuals' like cognitive weaknesses and also strengths, and also how that might be similar or different from like before the injury or events. And rehab psychologists can play an active team member in like a multidisciplinary rehabilitation team by, offering consultation and collaborating with other providers from other disciplines. And these things can occur like both in the inpatient and also like the outpatient setting. And I think in light of that, I think there's often a mistake that's made, especially outside kind of the medical and health community, in viewing brain injury as a discrete event, when really many brain injuries fit the World Health Organization definition of a chronic disease, which is something that can last a year or more and requires ongoing medical attention or perhaps limit activities of daily living. And so kind of thinking about like brain injury across the lifespan, we can see that, there's an importance of managing symptoms and experiences over time. And in the context of a brain injury, there are many changes and experiences that can occur both acutely and kind of ongoing. And this is by no means a comprehensive list here, but these are some common experiences and changes that can occur after a brain injury. So we can see that, they often fit into these domains of like cognitive, emotional, and physical changes. And, things like difficulties with memory or communication, depending on where the injury occurred in the brain. There's emotional changes like feeling more irritable, perhaps more anxious or depressed. And then there are these physical components of, fatigue and sleep disturbances. And all of these, or at least most of these can occur directly from the injury. So there might be neurological and structural changes in the brain that can lead to, say, difficulties with like memory retrieval. And then some of these things can also be caused like indirectly and be impacted by one another. So an example would be like you're noticing that you're forgetting more, and it leads you to become like more irritable or perhaps even like experience a lower mood. And again, all of these things can really be impacted and influenced by one another and also across time. And so there's this recognition, especially kind of from this rehab psychology lens, we try to employ this like biopsychosocial approach that kind of considers all of these factors and finding ways to kind of manage these things over time. And I just wanted to pause for a moment and kind of note that at least for the purpose of this presentation, when I'm saying brain injury, I'm really kind of referring to individuals who have experienced a stroke, a traumatic brain injury, anoxia, hypoxia events, a history of a brain tumor. And I just want to acknowledge that I recognize this is a pretty broad term that does not sufficiently account for the complexity and diversity of experiences and injuries in this heterogeneous group. So this is kind of like my form of disclosure, like not knowing all the intricacies of those attending today, or maybe like viewing this recording at a later time. But I think that the important thing that I wanted to note was that, not only do symptoms and experiences look differently from like one brain injury to the next, they also look differently like within a given individual over time. And then I just want to realize I didn't kind of open up and let you all know that I'll definitely leave some time at the end to answer questions. And if there are questions that pop up throughout this process, please let Carly know or type it in the chat. If I don't see it, Carly will let me know. So apologies for not saying that sooner. Okay. So along with kind of changes over time, I just wanted to highlight a couple examples of like how we see things look really differently for different types of injuries, and also how that looks differently from one person to the next. So over here, like on the left side here, you can see this is an example of individuals who have experienced a TBI. I believe that was moderate TBI here. And this is looking in this first year after having that injury. You can see that there's a lot of different trajectories. And when I say trajectories, I just mean this line, and it's kind of like an average, like a group's average experience over this first year. And so I recognize it's probably hard to see this, and that's okay, but you might be able to see kind of this bolded line here. And this shows like one group of these individuals who have experienced a moderate TBI to be experiencing pretty painful headaches at a more frequently over this year period. So this kind of y-axis here is a pain rating scale indicating like higher pain, and also these occurring with greater frequency. So there's this bolded group that has, I think they labeled it like a chronic experience of headaches over time, this year after a brain injury. And you can see this like dashed line here. Individuals are starting about the same rate as this chronic group. And then you notice that there's improvements where it kind of drops down here. And then over here on the right, I included an example of like stroke and experiencing fatigue, where they kind of divided these experiences into 3 different classes, where there are some individuals in the first 18 months after experiencing a stroke that have pretty low levels of fatigue. Some are kind of in the more moderate range, and then those who have a more high level of fatigue over these 18 months. And again, each line is like comprised of a group of individuals. So if we had individual lines for every given person included here, we would see like jumps and peaks all over the place. But we're saying on average, there are these different levels that we see. And then this example is actually kind of looking at over a wider range of time, where in this study, they followed individuals before even the onset of a stroke for a number of years. And this red line down the middle indicates a stroke for those who experienced it. And this y-axis is it's a measure of cognition. So again, this isn't all-encompassing cognitive skills necessarily, but it's one measure that's kind of looking at where individuals' cognition is with before stroke, and kind of what that looks like after stroke. And you can kind of see there's this dip here, and it kind of widens that gap from what we saw before. And so again, my point wasn't necessarily to like get into all the intricacies of these studies per se, but really just kind of zoom out and recognize that brain injury, stroke, it can really change trajectories of various domains of functioning. and what that might look like over time, especially when you compare it to the absence of an injury or stroke. And so finding ways to kind of manage these different symptoms and experiences presents as one of the most valuable tools that we have. And that kind of like leads to this health management component. So when I think about rehabilitation psychology and kind of our role, like I often think about like health management. It's kind of this like catch-all phrase. And I think health management can kind of be divided into these two components of, there's this like medical and professional management component where those are things like going to doctor's appointments, neuropsychological assessments, and going to your physical therapy appointments. And then there's self-management. And these are the things like, this is like your daily maintenance of what you're doing to kind of manage your symptoms and experiences. And I included this pie chart here, and I actually pulled it from another study that I was able to be a part of a couple of years ago, because I feel it's one of the most simplistically obvious illustrations of how we are really the key team members of like this like medical and like just like health treatment team. So if you were to kind of break down the time that's spent at doctor's appointments and assessments and therapies, it's this tiny little sliver when compared to like what we're doing every day to manage our symptoms. And yeah, so I think it's like less than like 1% of the time. And I also just want to note that, this is kind of looking at over time, the breakdown. I recognize that especially early on, this kind of like pie chart wouldn't look this way when there's a lot of time spent like at medical appointments, perhaps even in the hospital, going to a lot of appointments. But when we like kind of really look at managing things over time, we see that we take up a big, it really takes the cake, or I guess the pie in this situation. But in the best of worlds, we would hope that individuals can utilize and access both kind of this piece of medical and professional management, and also like self-management. And that's really kind of the key ingredients to like taking charge of your own health. So self-management, I included this figure from, it was actually a recent study looking at how people self-manage. I think it was the population was neurological conditions, including stroke, but some of the different strategies that people use, right? So they kind of nicely categorized it into process strategies and resource strategies. And you can see there are things like, just finding information. So going online, trying to get information, resource strategies like taking an active part in the conversation and seeking out care providers. And then there's like the disease controlling strategies. And those things might be like taking your prescribed medications. And so this is like a lot of different examples, and it kind of looks complex. And also I think the best way to describe self-management is just like what we're all doing like on a day-to-day basis to kind of just like feel better and pursue a life that is meaningful to us and a life that we also desire. And so I'm actually going to pause, and maybe we can try to utilize the chat feature right now. I'm curious, like when you think about like self-management and things that you are doing on a day-to-day basis, whether it's like managing like pain or fatigue, or just like managing, like what are existing strategies that you all use to self-manage?
You can type in the chat, or if you want to just unmute and share, you can do that way too.
Thanks, Carly. Maybe I'll offer an example.
Yeah.
Yeah, so I think, for the context of like, let's say fatigue. So there are many people who experience like fatigue after having a stroke or perhaps a brain injury. And one of the strategies that I often hear is, I take a nap in the afternoon for like 20 minutes. Like that is a means of managing kind of your energy levels, because for many people that gives them a little boost for continuing to engage in the other activities for the rest of their day. Some people find going on a walk to be something that actually helps with their energy, or perhaps can help decrease pain experiences.
Right, and a lot of the people on here might not be a survivor of brain injury themselves. They might be a provider, but just think of even your own life in general. I think we could apply it to, like, I have Crohn's disease, so I know, like, taking my medicines, eating better or eating healthier foods in smaller portions. Oh, Andrea put prioritizing certain things like going to a movie versus going to therapy. Very good.
Yeah. I see that. I like that. Therapies versus going to a movie. Light exercise daily. Yeah, like, and I actually appreciate kind of the light exercise daily. So like it might be something simplistic that we may not be recognizing as a pretty valuable thing that we do. One of the strategies I've just started to implement is I put my vitamins and all the things I need to take in the morning right in front of my coffee maker, because I never forget to drink my coffee, but sometimes I forget those other things. So they might be like really little things that we don't think about as like like a self-management strategy, but I would argue that each of us are currently doing things to self-manage. And I would argue maybe even attending these like webinars and kind of seeking out information is an additional component for like self-management. So yeah, thanks for those examples. Okay. All right, so we know from the research that self-management is actually one of the most important factors that can affect health behaviors and outcomes, and kind of like how we engage with our condition or with symptoms, and how that impacts those things. And in the context of brain injury, there's been a number of studies that have shown self-management interventions and approaches can help to increase individuals' confidence in their ability to manage symptoms. It can also lead to, there have been some studies that have shown increased independence and kind of carrying out basic activities of daily living. Some individuals have reported increased mood and also quality of life. And self-management interventions have been shown to reduce fatigue and pain. And that's really kind of the focus of the study that I'll be talking about, which is the ETIPS study. And so I'll call it ETIPS, and you're welcome to read the long-winded title here to know kind of what that is. But the aims of this study are really to kind of look at evaluate like an evidence-based telehealth pain self-management intervention, and compare that to kind of the usual care that people might be getting. And this is for individuals with physical disabilities who are employed. So we're looking at a number of different outcomes, including along with pain. And we're also interested in looking at, are individuals kind of adherent to the treatment process? Are they satisfied with the treatment process? And like, what are kind of the barriers or facilitators that come up during the process? So just a quick view of kind of like how the study is being conducted is we're aiming to get 200 employed adults with chronic pain and a range of physical disabilities, such as TBI and spinal cord injury, multiple sclerosis. And I do want to note that, like people in this study, they do have to be working at least part-time. And this is primarily because our funder, Neidler, really wants to focus on helping employed people with pain and disability. And so that's kind of where that focus came from. And those who are eligible and are kind of like enrolled, they'll get randomized. So it's kind of like flipping a coin, and individuals will either go into kind of this like usual care group, or they'll receive the E-tips like intervention, which involves 8 sessions. It's telephone delivered, and it's over the course of, I think those 8 sessions are completed within 10 weeks time. And then there's also like what we call a booster session after completion, where we kind of check in and see how things are going. And we're really interested in kind of understanding how the treatment affects pain, other outcomes that are influenced by brain injury and pain. And so I noted this earlier, but so NIDLR is funding this study. And aside from like being here at University of Washington, we're also doing it in collaboration with individuals from with the team at Northwestern in the Shirley Ryan Ability Lab. So it's kind of, for me, my role is working as like a study clinician, where I get to deliver the intervention. So it's been kind of fun to be able to work with people from all across the states, which is kind of like how we even like got connected here. Is I think our team reached out to Carly. So yeah. So shockingly, the study was actually up and running before COVID time. So the reason it's telehealth may not be like what you immediately think. Telehealth was chosen for a number of reasons, but also with the population in mind. So we know from the literature that chronic pain it's one of the most common causes of employment disability, absenteeism, and lost productivity. And most employees with physical disabilities and pain don't have access to some of these evidence-based pain self-management interventions. And we know that these interventions are really effective, like they work. There have been a number of reviews that have shown this cognitive behavioral intervention is pretty effective for both adults and also children in chronic pain who experience chronic pain. And another kind of reason for telehealth is that it's actually shown to be a pretty acceptable form of delivering this treatment. And I included this study up here, and actually the first author here is one of the primary investigators of the ETIP study. But this is a past study that looked at a similar self-management intervention for individuals with multiple sclerosis. And some of the outcomes showed that both participants and providers and therapists found it to be an acceptable delivery format. And they also found that it helped with treatment adherence and individuals showing up. I believe about like 95% of the sample said that they would like recommend it to a friend. I think 75% of them said that it was actually an important benefit of the study was having that telehealth option. And of course, you know, like some people do miss that like face-to-face interaction. And I believe from this study about less than half said that they missed that component. And still it seemed to be like an acceptable way to kind of have this intervention delivered. We also know that there are a lot of barriers to care. So especially people like with disabilities can face many barriers to like good healthcare, and transportation often is a barrier, right? Like not having a ride makes it really difficult to get to appointments. A lot of health offices are not always designed with patients with disabilities in mind. And one thing that I often think a lot, especially in the context of symptoms like pain and also fatigue, is when those things are our primary complaint, the act of commuting, even if it's a like relatively like short distance, can be pretty taxing, right? It might exacerbate symptoms. It certainly uses energy resources that might be better used for activities that are of greater value for an individual. So that's some of the rationale for why it's this like telehealth format. So I'll finally kind of get into talking about the actual intervention. And I just want to note, like, I'm going to kind of walk through some like foundational components and that, will hopefully be relevant and pertinent to those, whether you are qualified for the study, are interested in the study, or have no like attachment to the study. They're principles and foundational components that really apply to all of us in our lives. But the goals of the intervention are really to kind of like understand chronic pain and also how it can be influenced by thoughts and emotions and behaviors. And so that's this like cognitive behavioral approach, which I'll talk about a little more in like a couple slides. And it's really like developing new skills to self-manage pain. And this figure here is an example of kind of this like model, this cognitive behavioral model that shows all of these things interact with one another. And on the outside here, these are some of the skills and strategies that we work on in the treatment. So we employ this cognitive behavioral approach, and we also acknowledge and recognize the complexity of pain. So pain's really complex. And, the first session of the ETIPS study intervention, it focuses on a lot of education around this, kind of acknowledging like, it's really complex. It's this subjective thing that's often really difficult to describe. And on the left-hand side, I listed, some of the ways that the pain is described sometimes, but there's a lot of sensations. It fluctuates in severity and type. But we do know that pain is made up of at least these four things, where nociception, this kind of describes the electrical signals that are generated when something damages or stimulates a nerve. And then pain is when your brain creates the sensations of like some of those signals. And then suffering, I'm sure we all know kind of what that is, but these are the negative feelings that are created by the brain in response to that pain or the stress. And then pain behavior, these are the things that you do or the things that you say that can communicate to others that you feel pain. And we also know, to kind of add an additional layer, like we often hear there's like this acute pain and there's chronic pain. And when we think of acute pain, those are things that that's an experience that typically like doesn't persist beyond 6-ish months. And this is typically caused by trauma or some kind of procedure, and it goes away typically after that like tissue damage heals. Whereas chronic pain, which is the pain that we're working with in this study, this is an ongoing experience that typically goes beyond those 6 months. It can occur with no apparent tissue damage or past injury, and it can remain even after that damage has healed. And I included this, it's actually the revised definition of what pain is. And so you can see they kind of made it as like all encompassing as they could to be it's this unpleasant sensory and emotional experience. So that kind of fits the emotional component that we'll talk about. And it's associated with or resembling that associated with kind of this actual or potential tissue damage. And with that being said, like sometimes even the most sophisticated imaging, like an MRI, can't pick up and show damage for pain that is presenting and is very real. So it's complex, and it's also common, and it's common for individuals who have had a brain injury. I've included a couple points here, but the research is pretty extensive to support the high prevalence of pain in this population. People who have experienced a TBI are much more likely to have chronic pain, with about 75% of people with a TBI experiencing persistent pain, and about like somewhere around 30 or a little more % of those who have had a stroke experience that persistent chronic pain. And some of the most common sites are, headache, as I'm sure we could all guess, and back, neck, arm, leg, and joints. And again, this is all variable. And, even in the context of stroke, there's some research that shows how these sites and presentations can really change over time with, headaches can be more prevalent right after stroke, whereas some of the more like spastic related pain can peak in the longer term stages after experiencing a stroke. In the context of the ETIP study, we're really one of, the primary outcome that we're interested in looking at is what we call pain interference. So it's what it sounds. So this is like the extent to which pain might hinder one's engagement with physical, mental, cognitive, emotional, recreational, like social activities. So it's really like, how does your pain get in the way of your day-to-day? And we want to see kind of how this study and how these skills might impact that interference. So it's kind of focusing on this top layer here of, aiming to reduce the suffering by like managing pain through this like cognitive behavioral approach. So here's this like model again, and this is really providing kind of the framework for the study and the skills that we go over. And we know, and I've kind of alluded to this like in the past slides, but research has shown that people who are feeling pain, if they have their brain scanned, there are actually multiple areas of the brain that light up and show activity. So in addition to the area of the brain that processes some of that sensory information, the areas of the brain that also process thoughts and emotions, those are also lighting up and showing activity. So all this to say is that there's not just one single pain center in the brain. And because of this, there's this recognition that we can get control over many of the systems that are involved in the pain experience in a way that might help reduce the intensity or severity or just our experience of it overall. And in any given situation, we all have thoughts and emotions and physical reactions and things that we do. And all of these things influence each other and can impact our experience with pain. And so I'll kind of walk through an example of this. And I mean, some of you may be familiar with kind of this model. The example that I used to frequently give was getting stuck in traffic. And I found a more relevant alternative to that these days is like when your internet is not working, because that's our form of commute often during COVID times. So in this situation, okay, you're like logging on to maybe a meeting or something, and your internet connection drops. In this example, there's this individual is having thoughts of like, oh my gosh, like this always happens to me. Like whenever I need to get on to a meeting, my internet goes out, like I'm gonna miss my meeting. These kind of thoughts tend to like foster emotions of feeling frustrated, anxious. You might find yourself clenching your jaw with that frustration, or perhaps like aggressively clicking that little like Wi-Fi icon in the right-hand corner on and off. And all this, like our body is also reacting. And this individual might have increased heart rate. There might be more tension in the shoulders. And we know that, muscle tension tends to like increase pain. So this is an example of just how, and although I did kind of walk through this linearly of like thoughts lead to emotions, lead to behaviors, you can see there's these arrows going every which way and they're all interacting with each other, and they can all like have an outcome, like have effect on the outcome of the situation and like our experience of it. And so, the same situation can have very different, reactions of an individual just by the way that we might be thinking about it. And so this is the same exact situation here with some different thoughts. So, and I have to say, as I was like creating this example, I was like afraid that I was gonna make my internet like shut off and manifest that. Hasn't happened, knock on wood, but so the thought here is, I know some things that I can try that have helped before. If this were to happen to me, then I would have maybe like sent an email to Carly and been like, hey, internet's out. Would have done that on my phone so I wouldn't have internet. But you can see like these thoughts like are a little different than the last series of thoughts. So when we think about this, you're welcome if you guys want to kind of like use the chat feature. You're welcome to. How do you think like these types of thoughts might impact the emotions that follow? And it could include a lot of different things. I'll give just a couple moments. It's not a quiz per se, but when we have thoughts that perhaps are a little bit more reassuring, they might lead to different emotions, such as there might be less frustration experienced. There might be more calmness, hopefully. And when we're a little more calm, we're also able to kind of do things that might be a bit more constructive to the situation. We might even take a couple breaths. We might turn the router off and on because that's helped before. And our body isn't accelerating and tensing up at the same rate. And so this is just kind of an example of how, if we're to think about things differently, then it could potentially lead to these different outcomes, which overall can impact one's pain experience in a given moment. So the ETIP study, it's really a collaborative process. So although there are certain things that we of course want to like address and make sure we touch on, they're really tailored to each individual. So every session kind of starts out with reviewing activities from the week and kind of seeing how they went, like celebrating successes and kind of brainstorming like what got in the way, how might we want to do things differently. We do in-session activities together, and I'll give an example of that in the next slide. And then we really adapt kind of the content to their specific goals and interests and values, right? So there are some individuals who are really frustrated with how pain is getting in the way of their productivity at work. And then there are others who are frustrated and want to work on kind of increasing their activity because they found pain has led them to do less and become a bit more inactive. And some of the activities that we do, we do a relaxation activity almost every session, and we'll actually have the chance to maybe walk through one briefly, but we really try to tailor them to the disability because there are individuals presenting with a range of disabilities. There are some individuals who might not have a limb, and oftentimes we focus on different parts of the body. So we try to get a good understanding of how people are presenting, how their disability and pain is presenting, and how these things might intersect with the treatment form. So this is one example of an activity that we actually kind of touch on over a couple weeks. And this really fits into the cognitive goal of the treatment, which is learning to recognize and kind of evaluate how you react to your pain, both in terms of your thoughts about the pain and also what you do when your pain increases. So in this example, and we kind of build on this across sessions about, this person shows up late to an appointment, pretty similar to what we walked through. And we encourage individuals to just start writing down the thoughts that are happening. And we note that thoughts happen so quickly, we're very often not even aware they're happening. So the first step is really paying attention to like, what is going through my mind? And also like, what is my body doing? How am I feeling? And like, what am I doing in these situations? And this is one example that kind of provides this like structured way to kind of examine patterns of thinking, particularly in response to like pain and stressful situations. And it helps us to slow down, identify automatic thoughts, kind of evaluate like, if are they helpful? Are they making things worse? And once we kind of identify that, then we start to work on challenging these things and kind of developing alternative thoughts that like foster a bit more hope and allow us to cope a bit better when we are experiencing increased stress or perhaps pain. And while I would love to do an example of walking through like a thought record for all of us, I felt that that might be a little tricky, but I thought we might maybe do a quick little in-session activity. And this is one that we actually incorporate in the first session of the ETIP study. So we talk a lot about relaxation, and that kind of maps onto this behavioral goal where we want individuals to learn skills for managing pain and managing stress. And we introduce a variety of relaxation skills and other skills really so that individuals can try them on, see if it's helpful or not, and then they can kind of proceed to implement them in their lives. And so this is like a deep breathing exercise essentially. And the reason we talk so much about relaxation is, we know that tense muscles make pain worse. And relaxation can help to decrease muscle tension that can contribute to pain by initiating the parasympathetic nervous system, which kind of counteracts that fight or flight response that we might be familiar with. And relaxation, it also appears to have an effect on the areas of the brain that might be involved in kind of that pain perception. And so diaphragmatic breathing is essentially just deep breathing. And we introduce it at the beginning because it's one of the easiest and the most effective relaxation skills. So we know like the diaphragm's this like dome-shaped muscle under the rib cage, and during like correct diaphragmatic breathing, the diaphragm it's tight and it pulls the lower parts of the lungs down so that more air can be inhaled. So this act of breathing more deeply allows kind of that heart rate to slow in rate, and it can kind of induce that calmness, relaxed state that is what we hope to be the opposite of like the muscles tensing and even like jaw clenching. So really to kind of loosen overall. So I'm actually gonna, because we have the time, I'm gonna walk through kind of a brief activity, and maybe we can do a couple just breaths. And I actually, let's see. Yeah, so for those of you who want to join in on this, feel free to do it. I think most everyone's cameras are off, but usually I offer people to like turn off their camera if they do want to do it. And I also, at least in person, I always tell people, like I'm not going to stare at you when you're doing this. So for that reason, I'll maybe turn off my camera as well. Not that anyone is kind of on here, but maybe go ahead and like just get into a comfortable position. And feel free to adjust kind of throughout the exercise. It'll be pretty brief, but just to increase your comfort level. And go ahead and just turn your attention to your breath. And you no need to change it yet. Just notice what your breath is doing. Maybe place, if you have access and are able to, you can place one hand on your stomach. You might place the other on your chest and just continue to breathe normally, and notice which hand might move, maybe more. Most people find that the hand on their chest moves a little bit more, and that can indicate a person is breathing in a more shallow manner. So now try to take a breath from your stomach, and it might feel like you're pushing out your stomach, and that's the way it should feel. But maybe close your eyes if you haven't, and take a deep breath in through your nose and feel the hand on your stomach rise as you inhale. And then breathe out through your mouth, just noticing the hand on your stomach fall as you exhale. Just continue to breathe like that for a few moments. If you want to walk through the steps on your own, I've put that on the screen, but if not, just turn back to your breath. And again, take one deep inhale through your nose. Hold it at the top maybe and breathe out through your mouth. And you might notice that your chest moves as well, and that's okay. Just continue to focus on breathing with your abdomen as much as you can, trying to fill your lungs with all new air. And then exhaling out all the old air. Maybe just take 1 or 2 more breaths on your own. And whenever you're ready, you can open your eyes if they were closed. And if at any time you start to feel lightheaded, sometimes people notice that when they kind of shift from the more shallow to deep breathing. But just resume kind of your regular breathing until those symptoms go away. And most people find that those symptoms disappear as they practice and their body adjusts to some of that deep breathing. Okay. I just turned back on my video to kind of orient us back here. So this is just one example of the activities that we do in the session and also encourage individuals to do outside of the sessions. And I think that's a big component of the ETIP study, is really about practicing the skills on their own time, and practicing them before we're in these heightened moments of stress or pain. I kind of like the example I often use is, you know, if you have like a getaway car and it's stick shift, like you don't want to learn how to ride stick shift when you're like fleeing the scene, right? You want to practice the skills when you're able to be calm and kind of really focus on the skills, so that they become more accessible at times that they might be needed most. So the outcomes of the study, let me see, are not yet known because they're still recruiting participants. But what we have noticed is that for those who have started the treatment, they are tending to like finish it because they like it, or they're finding that they're getting something from it. So that's encouraging for us, is that people are sticking with it, and they've expressed that they're learning new skills, or kind of, at least a lot of the participants that I've worked with, they haven't found like a lot of the skills haven't been these novel things that they've never heard of, but they've started to practice them a little bit more frequently. And so they're starting to notice getting something from it. And I kind of, we got this one comment from one of the participants, which I thought was pretty impactful, that you know, they couldn't even remember the last time they took tramadol. And so I can't say this is what all patients, all participants experience, but I think it's encouraging for us, especially on the research team, to kind of see that individuals are at least enjoying it and kind of showing that. But really, regardless of being in the study or not, I think the point of kind of talking about the study was really just to introduce the fact that we can all do things, and likely we are all already doing things that can really help us to self-manage pain, to self-manage other experiences. I'm aware that, you know, everyone here, you know, may not be a survivor of brain injury, but like Carly mentioned earlier, like I would imagine most of us have things that are bothersome or stressful, like, I don't know, like a pandemic and like overwhelm and exhaustion. These are all things that we can self-manage on our own. And so So I included just like, I mean, these are some of the skills that we go over. And also these are things that can be done independently, like outside of the study, that research has shown to be really helpful for kind of managing and improving different aspects and functioning in our lives. Self-monitoring, we didn't touch on too much, but this is, I would say, like one of the most important things that we can do, because when we can kind of like keep track of things that we maybe want to better manage, change, or understand, like the act of just like noticing it is like a huge practice, right? We can become a little more aware of symptoms and their effects. We can become aware of like potential triggers for symptoms or behaviors. And so some people will just kind of write down whether it's thoughts like these are the thoughts I'm having, or some people will develop their own, like pain scale, like on a scale of 0 to 10, where's your pain? 0 might be like, a 0 is like my experience when I had no pain before my injury. A 10 was like right after this procedure. So like developing your own rating scale that makes sense for you, and tracking like, in the morning, where's my pain at, or where's my stress at, like in the afternoon, like, so just documenting things to kind of notice over time, like, are there any patterns that maybe I'm not aware of? And then once we start noticing these things, then we can start working on them. And goal setting is a really helpful skill for moving ourselves to, maybe engaging in more activities or doing things that we want to do. And we talk about SMART goals, and I don't know if you are all have heard of that, but we want goals to be very specific, so we know exactly what we're aiming for. We want them to be like measurable so that we know once we hit them, right? So like, I want to walk for like 20 minutes, 2 times a week. Like that's specific and measurable. It's also time bound, which is, I jumped to the T of SMART, but you want goals to be specified in a way that it's so obvious once you've met those. And when we kind of set these goals, it not only helps to increase these activities, it also builds a bit of motivation for like continuing. And then I skipped over the A and the R, but A is being like, we want it to be achievable, and we also want it to be relevant. So I always say, like, especially starting out with setting goals, you want to set yourself up for success. Like you want to, like, even if you think you could do more, like you want to set it lower so that that you're confident that you can achieve that, right? We don't want to go from like, yeah, I haven't been, exercising throughout the pandemic, but this week I'm gonna go on a walk for like 3 miles every single day. Want it to be realistic so that we can continue to feel motivated for engagement. And as we do that, we also want to kind of take into account like pacing and energy management. So especially those with like chronic pain or fatigue, they have a tendency to maybe push themselves, especially on days where maybe they're feeling a bit better. There are often this temptation to like, I need to do all these things that I wasn't able to do in the past couple of days. And then they find that the next couple of days they're out resting and trying to recover from that overexertion. So again, like pacing and even incorporating distraction strategies. Distraction provides kind of like a temporary break and maybe unhelpful patterns of thinking or behaviors. It might be something like listening to music or a podcast or like binging on a show. And I think the important thing here is it's a short-term solution as we try to focus on more of these like long-term goals and solutions. And then, coping thoughts, like finding a coping statement that you believe and makes sense to you, whether it's like, I know this is not going to last forever, or I've been through similar things before and I found ways to manage them. And then relaxation. We now have at least like one relaxation skill in our books now, like just doing a few deep breaths each day, finding ways to kind of induce that state of relaxation to give us a certain clarity and calmness for moving forward. But again, these are just some skills that have shown to be helpful for kind of managing different symptoms and changes that can occur in the context of brain injury. And again, I think we're all already doing a lot to self-manage. So a big part of it is like giving yourself credit for what you're already doing to kind of manage on a day-to-day basis. So just to kind of wrap up, I mentioned this earlier, but this is just kind of the info for our funder of NIDLR and kind of the grants that eTips is associated with. Here are a couple like key personnel members from the eTips study, and kind of they've really launched this study to what it is. And our research team at UW, who kind of handles a lot of the logistics and really has like got it up and going and throughout the pandemic, and have allowed us to kind of get where we're at. So I've included information about the study here. And also I was talking with Carly, and we can like link it if you're interested and feel like you might qualify, or if you know of someone, or if you even like are a provider and want to share the information. This is something that you could certainly share, and you can get in touch with me or with Carly, or the email here to get even like a flyer printout. I think this is actually a screenshot of a flyer. But again, we certainly wanted to introduce the study, and also just want to acknowledge that you know, it's the components of the study that I hope are like applicable to those who have kind of like stuck with this little webinar to the end. But I know I kind of opened it up to questions throughout, but I'll pause my rambling and see if there are any other questions or anything you want to add, Carly.
Oh, that was great. Yeah. Any questions at all? I think this fits in, yeah, well, obviously because we deal with brain injury, but you know, I think so many people are just looking for like a quick fix and an answer for pain, and it's not always that simple. And I know we had a client that went down to Florida to some kind of pain management clinic, and I think she was expecting the magic pill when she got back, and she's like, they just taught me how to like breathe deeply, which is yeah. So I think it's important though that people know that what the benefits of that can be, and that it isn't often a medication. It's more of like the mental part.
Yeah.
So
yeah, those people who maybe joined in today were probably disappointed that it's not a magic pill.
No, that's okay. Yeah. But yeah, I definitely encourage, I think most of you on today are providers. We have a couple survivors names that I recognize, but yeah, I definitely think this is something that if you're interested in helping them out with, it's a really good study to participate in, and you'll hopefully get some relief from your own symptoms and help others along the way.
Yeah, absolutely.
Yeah, so Jamie is going to send me like a link to that last one with the slides with to how to participate if you'd like to participate or know someone that would want to participate. Would you mind sharing your slides with me too, or is that?
Oh yeah, I'll go ahead and I'll
send those. I did get an email. Tracy emailed me and asked if they could get them, and I will put those up I'll put them in that same spot where the recording is. So the recording and the CEU request and the link to participate in the study will all be in that same spot where we archive all of our other Webinar Wednesday stuff. So seeing no questions, and anybody else? Last call for questions. Great information. You were just so thorough.
Yeah, well, thanks for having us come and talk about it. And again, if there are any questions, I know I recognize the study is not pertinent for like everyone. And also for those of you who maybe have like friends or work with individuals with brain injury, it could be a resource now or potentially later. So we're still in the recruitment process. So just to have it on hand, and also kind of maybe might spark some ideas for other connecting resources in your own areas and fields. So
hi, this is Yeah, I'm sorry. I don't know how to use the chat function. I'm on my
That's
phone.
okay.
Wanted to say thank you very much. I thought this was a really informative presentation and the study sounds fantastic. I can't wait to see the research on it, and hopefully maybe you guys will publish some manuals or protocols on this, because I think it's really helpful information. So thank you.
Yeah. Oh, thank you, Tracy. Yeah, we'll definitely, I look forward to when we can kind of like publish what we find and also kind of have some more resources for others to have access to. But thanks for that comment. Well, it sounds like we'll have all the resources that others might want or need at a later time. Thanks for Virginia for your comment as well in the chat.
All right, Jamie, thank you so much for your time, and good luck as you continue on your schooling and all that. And we're looking forward to reading about the study when it's all done.
Yeah, we'll definitely have to loop you back in when that happens down the road. But thank you for having us and asking us to talk about it. But hope everyone has a good rest of their day and a good rest of the week.
You too.